সকাল সবাইকে আমন্ত্রণ জানাচ্ছি এখন টিভির স্বাস্থ্য বিষয়ক নিয়মিত আয়োজন আরোগ্য নিকেতন। আমি ডক্টর তমাল আর আমার সাথে আছেন আমার ডান দিকে ডক্টর পেরেরা, উনি সিঙ্গাপুর থেকে এসেছেন। ডক্টর পেরেরা ইজ এন হাইলি ডিস্টিংগুইশড ডক্টর with multiple awards and guest lectures in over 100 conferences nationally and internationally. He has over 138 publications to his credit. His area of interest is basically medical technology in glaucoma and cataract, imaging and surgical devices. We are very glad to have you, Dr. Pereira, here, and we from Asghar Ali Hospital welcome you with open arms. Thank you very much for giving us some of your valuing time, and we hope to be enriched with your vast knowledge of glaucoma.
Thank you very much for the kind introduction.
Thank you. এবং ডক্টর মোহাম্মদ আরিফুর, উনি সিনিয়র কনসালটেন্ট at Asghar Ali Hospital. He has a special interest in glaucoma. আজকের বিষয়বস্তু জনগণ হচ্ছে গ্লোকোমা। আমার সঙ্গে যিনি আছেন তিনি কিন্তু ইন্টারন্যাশনালি গ্লোকোমা নোন স্পেশালিস্ট। ফার্স্ট কোয়েশ্চেন টু ইউ, হোয়াট ইজ গ্লোকোমা? হাউ উড ইউ ডিফাইন গ্লোকোমা?
So glaucoma is a group of diseases that are characterized by a specific type of optic nerve damage. That's the nerve that carries the information from the eye to the brain. This is accompanied by a particular type of visual field loss, typically in the periphery first before coming into the center. These can be associated with high pressure, but not always. But high pressure inside the eye is the most easily treatable and modifiable risk factor for glaucoma.
Okay, so can we have high raised pressure and no optic nerve damages? Is it possible?
Yeah, absolutely right. So the nerve has some capacity to absorb the pressure without getting any damage, especially in the early stages. And we call that disease ocular hypertension. So there's high pressure inside the eye, outside the normal range, but it's not causing any damage yet. But of course, if left untreated for a long period of time, and depending on how high it is and the strength of the nerve, that pressure can eventually yield some damage. As soon as it causes damage, then it's called glaucoma.
Right. তাহলে দর্শকজন একটা জিনিস কিন্তু বোঝা গেল, চোখের হাই প্রেশার মানেই যে গ্লোকোমা তা কিন্তু নয়। চোখের হাই প্রেশারের সাথে আমাদের চোখে একটা অপটিক নার্ভ বলে একটা জিনিস আছে, যে জিনিসটা দিয়ে চোখের সিগন্যালসগুলো কিন্তু আমাদের ব্রেনে যায়। সেইটা যতক্ষণ পর্যন্ত না এফেক্টেড হচ্ছে আমরা কিন্তু গ্লোকোমা বলে সেটাকে লেবেল করি না। দ্যাট ইজ অকুলার হাইপারটেনশন। আমরা পরে জানবো যে অকুলার হাইপারটেনশন কীভাবে কখন ট্রিট করতে হয়। তার আগে আমি ডক্টর আরিফুর রহমানকে জিজ্ঞেস করব, এই যে গ্লোকোমা হলো এটা আপনি ডায়াগনোসিস করলেন কিভাবে, কিভাবে করবেন ডায়াগনোসিস?
ধন্যবাদ ডক্টর তমাল। আসলে গ্লুকোমা ডায়াগনোসিস তো অনেকভাবে করা যায় আর কি। আমাদের দেশে যেগুলো করি আমরা, যেগুলো সেটা হচ্ছে প্রথমত যারা রুটিনলি একটা এজকে ধরা হয় 35 বা 40 ইয়ার্স অ্যাভাব আসে যখন, তখন তাদের প্রথমে একটা রুটিন টেস্টের মধ্যে আমরা চোখের প্রেশারটা দেখি, চোখের চাপ। তাছাড়াও যদি তখন ওখানে কিছু সন্দেহ করা হয়, আরেকটা জিনিস দেখা হয় অপটিক নার্ভ। অপটিক নার্ভের যে জিনিসটা চোখের ভিতর থেকে দেখা যায় ওটাকে বলে অপটিক ডিস্ক। ওই ডিস্কের ভিতরে কিছু পরিবর্তন আছে, ওইগুলো দেখে আমরা প্রাথমিকভাবে সন্দেহ করি। তারপরেও যদি পেশেন্ট কোনো রিস্ক থাকে তখন তাকে বিশেষ কতগুলো টেস্ট করা হয়। ওই যে উনি যেমন বললেন ভিজুয়াল ফিল্ড, তারপরে আছে আপনার অ্যাঙ্গেল অফ দ্য, ওই চোখের একটা অ্যাঙ্গেল আছে অ্যান্টেরিয়র চেম্বার, এগুলো সম্বন্ধে হয়তো পরে কথা বলবে। ওইটা দেখা হয়। মানে মূলত চোখের প্রেশার, ভিজুয়াল ফিল্ড এবং এখন নতুন কিছু ইনস্ট্রুমেন্ট এসছে যেমন ওসিটি, এটা অনেকটা চোখের এমআরআইয়ের মতো। ওসিটি করেও অনেক সময় নার্ভের পরিবর্তনগুলো আর্লি দেখা যায়। এইখানে আমি ওনাকে একটা প্রশ্ন করতে চাই। আই লাইক টু আস্ক ইউ ওয়ান কোয়েশ্চেন। অ্যাকচুয়ালি হোয়েন উই স্টার্ট treatment in case of though we don't know it is glaucoma or not, because you told when optic nerve is involved, then glaucoma. Suppose one patient, he has 25, 26 IOP, optic nerve is normal, visual field is normal. How long should we wait to start treatment for this type of patient?
So basically he's asking you the treatment of OHD, ocular hypertension, and the schedule and the follow-up. How would you treat such a patient?
Right. So the first thing to say is that there has been a very good study on this done already. It's the ocular hypertension treatment trial. Now, they ask us to look at a few factors. So one is the age of the patient, the height of the high pressure, and also the corneal thickness.
Yeah.
The corneal thickness is used as a surrogate measure of how strong the nerve is and how able to withstand the pressure. Okay? In patients where there's no other risk factors, for example, they don't have a family history, or there's no other signs of any secondary glaucoma, and it's definitely an open angle, we can generally wait for a while. Now, it also depends on the patient. We have a discussion with the patient, and if they have a particularly worried personality, then they may elect to go and start on treatment even with a pressure of 25.
Okay.
There are certain conditions where we really must treat, and that's when the pressure goes over 30, because at that stage they can get vein occlusions, and that can damage the vision irreversibly very suddenly. So generally speaking, we try to wait as much as possible. But if the pressure goes over 30, there's any signs of any early nerve damage on the optical coherence
What would be your follow-up schedule?
So again, we would usually like to make sure that we've got a series of tests done at the baseline, so we can have a good optic nerve disc photo. Then we will have a series of OCTs, optical coherence tomography tests, and also a series of Humphrey visual fields, which are reliable and show no damage whatsoever. We'll often see these patients about twice a year or so.
Okay. Since you mentioned Humphreys and OCTs, I have a question for you. A real life scenario. Patient is illiterate, which we get to find here. She cannot press the button in the Humphreys and the false negative and false positives are very high. So we need to assess our OCTs. How reliable do you think is OCT, only the OCT, prognostic indicator in the management of glaucoma?
Okay, so again, there have been studies on this already that look at several parameters on the OCT, and it's what we call the diagnostic capability. So initially, when you look at some of the parameters, they have a sensitivity specificity around about 0.8 on each one. But actually, as we've moved on with the technology, and we can now look at factors like the GC-IPL, these are factors centered around the macula, and we can get even higher levels of concordance with glaucoma diagnostics. So as we've moved on with more sophisticated tests and more accurate tests, then we can be more certain about the diagnostic capabilities of the OCT.
Okay. Arif sir, একটা প্রশ্ন আপনাকে, আমরা তো ওসিটি করি এখানে রেগুলারলি, ওসিটি আর এনএফএল করি, আর আমরা ফিল্ড টেস্টও করি। তো আপনার কি মনে হয় যে ওসিটি করে আমরা ট্রিটমেন্ট, তো উনি বললেন যে এরকম কিছু কেস আমরা করতে পারি, অনেক সময় আর এই দুটো হয়, তো আমরা যখন আমি ট্রিটমেন্টটা শুরু করব, কিভাবে শুরু করব? আমার ফার্স্ট লাইন অফ ট্রিটমেন্ট কি হবে? এলিভেটেড প্রেশার আছে, তার ওসিটিতে একটুখানি অ্যাবনর্মালিটিস দেখা গেছে, সে ফিল্ডে একটু প্লাস মাইনাস আছে, খুব একটা বসে, এবার আপনি কিভাবে ট্রিটমেন্টটা করবেন?
আচ্ছা, এখানে ওসিটি চেঞ্জ দিয়ে আমরা খুব আর্লি, ইভেন অনেক সময় ভিজুয়াল ফিল্ডে ওটা ডিটেক্ট হয় না, কিন্তু ওসিটির মাধ্যমে আমরা আর্লি ডিটেকশন করতে পারি যে গ্লোকোমা চেঞ্জ ইজ গোয়িং অন। রাইট। যদি তার এমনি কতগুলো মানে রিস্ক ফ্যাক্টর আছে, যদি ডায়াবেটিক পেশেন্ট হয় বা যদি মায়োপিক পেশেন্ট হয়, এগুলো তো রিস্ক ফ্যাক্টর, ফ্যামিলি হিস্ট্রি থাকে, এই সমস্ত কেজে আমরা যেটা আমাদের এখানে স্টার্ট করি, আমরা সাধারণত ইউজুয়ালি উই স্টার্ট উইথ মেডিসিন ড্রপস। ইউজুয়ালি ওই বিভিন্ন ধরনের ড্রপ আছে, ওই যে ল্যাটানোপ্রোস্ট অথবা টিমোলোল।
স্যার, আপনার চয়েস কি হবে? which medicines would you initially prescribe?
আমি প্রোস্টাগ্ল্যান্ডিন অ্যানালগ যেটা, ওকে, ওইটাই স্টার্ট করি প্রথমে, মানে সিঙ্গেল ডোজ, বিকজ ইট ইজ ইজিয়ার সিঙ্গেল ডোজ। ইফ ইট ইজ নট কন্ট্রোলড, দেন you go for others. In this case, can I ask one question to
Please.
him? Yes. Actually, we are talking about how we start the treatment. Usually, we start here prostaglandin analog or timolol or like this one. So, can I ask you what you start? What about the role of the laser SLT in case of there? Should we start medicine first, drop, or should we start laser and other things? Just I want to know what is your experience regarding use of SLT and others.
Sure. So SLT is a treatment that we've had for a long, long time. SLT stands for selective laser trabeculoplasty. But in a recent study, we've moved it up the treatment ladder to first line.
Okay.
And basically, in this study that looked at the efficacy and cost effectiveness and quality of life of using the laser as a first-line treatment in newly diagnosed glaucoma patients compared to drops. The laser came out doing very well and was shown to have a IOP lowering, which is very significant and kept the patient at bay in 68% at 6 years. So that was very effective. Far more effective than we thought initially.
That's
and
good.
now in several countries, including the UK and in Europe as well, the laser has been moved up to first-line therapy, especially because it's very cost-effective in those countries.
And how long do the effects last?
So in that study, with the proviso for some retreatments, they had a 68% reduction in stability of control of the glaucoma at 6 years, which is very, very good.
At 6 years?
Yes.
That's phenomenal.
It's phenomenal, exactly.
That's phenomenal.
Yeah. The thing is that in our local population, sometimes patients are not so amenable to having a laser treatment. Sometimes there's negative connotations around laser treatment. But I say to my patients, if I was diagnosed with open-angle glaucoma right now, I would happily take the SLT laser. Now, the thing is that in the UK study, which this was based on, it's called the LIGHT study, which is always a good name for a laser study. The treatment's free.
Okay.
So that changes the issues a little bit.
issue here in the third
in
world
Singapore
countries,
and I presume in Bangladesh, they would have to pay for the laser, and the laser can be quite expensive, especially now that drops are relatively cheap. So hence, often our patients will elect to go for the drops first, unless they're particularly forgetful or they have tried the drops and have got side effects for it, then they will elect to go for the laser. But the laser is a very good treatment, and we have been doing more lasers now than we ever used to before, you know, with the information that we have now about the SLT as first line from the LIGHT study.
দর্শকগণ, একটা তাহলে আমরা এই আলোচনা থেকে জিনিস যেটা বুঝতে পারলাম, গ্লোকোমা ট্রিটমেন্ট সম্ভব, গ্লোকোমাতে কেউ সেরকম অন্ধ হয়ে যায় না, এবং সঠিক সময়ে ডায়াগনোসিস করলে পরে আমরা কিন্তু এই দেশে, উনি যেরকম বলছেন বিদেশে ওনাদের ওখানে লেজারটা খুব প্রচলিত, ওনাদের ওখানে লেজারটা ফ্রি, কিন্তু আমাদের এখানে সবথেকে ইউজফুল এবং প্রচলিত হবে আমাদের টপিক্যাল ড্রপস। এই ড্রপস দিয়ে আমরা চোখের প্রেশার কমিয়ে গ্লোকোমাটাকে আমরা কিন্তু কন্ট্রোল করতে পারি।
ডক্টর তমাল, আরেকটা লেজার আমাদের ইউজ করে একটু চিপ, এই ব্যাপারে একটু জিজ্ঞাসা করুন না আমি ওটা ইউজফুল কিনা। আচ্ছা, ওয়ান মোর কোয়েশ্চেন, somewhere in our country, in case of established glaucoma, because most of the patient is not compliant in our country, they not continue medicine.
Same everywhere.
So they use cyclodiode lasers. Have you any idea about regarding this? How is it permanent? It is cyclodiode laser. They even use it as a part of
as a first line treatment.
But I thought cyclodiode,
some sort of glaucoma patient, they can use it. In Islam,
but I feel that is only for end case glaucoma where you can't do much, you just need to lower the IOP. I have done several cyclodestructive procedures, but that is what I look at. I mean, I don't think that would be a part of treatment of the glaucoma per se. Okay. So, do you agree that prostaglandins are your first?
Yes. So in most regulatory institutes where you have like a governing body, so for example for our region is the Asia Pacific Glaucoma Society, they have guidelines like the EGS for the European Glaucoma Society or the AGS for the American Glaucoma Society. They will always put prostaglandins as first line.
First line?
Yes.
Of the 4 prostaglandins that we commonly know, which one would you use?
Okay, so which ones do you have?
So we have latanoprost, we have travoprost, bimetoprost is available. Normally they get it from India, I mean they get that. and last is tafloprost.
Okay.
So which one would you use as the first?
Right. So the thing is, they're not all equal, and there are subtle differences between all of them. I think I can suppose generalize and say that most people think that bimatoprost is a little bit stronger than the others, and it's been seen in many studies as well when you look at it on a very large global view. The tafloprost has an advantage in that it comes in a preservative-free form as well, in the unique little mini dose vials. So again, you can just put it in and throw it away. And also you can keep track of how many you've used as well. So it has several advantages in that case, especially in patients with ocular surface disease. You're not giving any extra preservatives to the eye.
Yeah.
Generally speaking, the latanoprost, the travoprost, and the bimatoprost also have certain problems because of the preservatives that are involved. So we know that BAK, benzalkonium chloride, is useful in terms of it's an antiseptic. It keeps the bottle free from any microbes.
But
however,
it does cause problems
to the ocular surface.
So would you choose bimatoprost
as first line?
First line?
So it's different in different healthcare systems because we have a subsidized drop, which is latanoprost.
Okay.
Latanoprost has been used for many years.
Okay.
It's generally all purpose. It's very good, yeah.
Thank you very much, sir. Amra ekta break nebo, so we'll take a short break now, and then we'll resume our talks again. It has been very enlightening so far.
Thank you very much.
Arif sir, we will be starting now again. So that was a break. Suppose a person, I am addressing the question both. Suppose a person is not controlled with 3 medications. So the indications are obviously surgery. What surgery would you use?
Okay, I'll let you go first.
In our country, actually, if it is not controlled, which one is gold standard still, I think, is my little experience. I am not very much here. Trabeculectomy we prefer first.
Sir, trabeculectomy or trab with mitomycin, 5-FU, whatever?
Mitomycin we can use.
No, what would you use?
If there is, personally, what I do, if he has no other secondary risk factor, without mitomycin I
so standard trab.
Standard trab.
So in Singapore, our population is predominantly Chinese. Yeah. We have a certain amount of Malays and also Indians as well. And we use mitomycin as standard for all our trabeculectomies.
Yes.
The risks of scarring are quite high in our population, even higher in Afro-Caribbeans, but less so in Caucasians. So we modulate it. So in our population, we use mitomycin as standard.
I too use mitomycin as standard in all my trabs, and I've got very good results, be it primary or secondary. The other thing that I look at is the kind of nerve damage that the patient has.
Absolutely right.
The patient has pressures of 25 and 0.8 cups. I would aim for a treatment pressure of around 12 or 13. So mitomycin is the treatment of the choice at that time.
Absolutely.
And the worse the condition, angle recession, glaucoma, or a blunt trauma, or whatever, so mitomycin would. What dose of mitomycin do you regularly use?
Right. So we give the mitomycin in 2 different formats. So you can either give it on sponges, which is the traditional method that we've all learned from many years ago, or nowadays a lot of people are moving to injections. So traditionally in our population, we'll use 0.4 milligrams per mil and use it for 3 minutes on sponges.
On sponges.
Now, if you're injecting it, because it's stronger, it stays in the tenons layer, and you inject it intratenons, you can go to half the dose.
So
you go down
not 2
milligrams per mil mitomycin, injected intratenons, and then you flush with water, 50 mils of saline.
So, but that stays in the tenon.
It does.
Yes.
So throughout the postoperative care also it will stay?
It's neutralized as soon as you put the saline over it, but it delivers it to a much wider area, firstly. Indeed. Secondarily, you don't have any of the problems with sponges. Sponges can be lost.
I'll try that. I've never tried it. So you actually inject it in tenons or in conjunctiva?
Intratenons.
Into the tenons. Yeah. So normally you do not excise the tenon.
So no, we don't do tenonectomies.
You don't do it in an.
And we deliver it at a stage before we've gone into the eye.
So you made the scleral incision and then you give the injection?
No, before scleral incision, it is given over the near the fornix.
So if you can,
under the fornix, it is given widely.
So I'm doing a limbal based. I'm doing a phonics based. So I have
done
separated the conjunctiva and the tenons.
So you can either inject it at that point, and you inject it quite far back. And it has another advantage because, you know, in the very elderly patients who don't have much tenons,
right,
and it's recessed back.
Yeah.
It puffs up the tenons and brings it forward. Which makes it easier for you to reoppose that to the limbus. So again, it has another advantage.
Excuse me 1 minute. What about use of collagen tissue in trabeculectomy? How is the result? Have you done it?
So you're speaking about Ologen.
Yeah.
So we published 2 papers on Ologen from our center.
I did a lot of patients with Ologen, so I am asking you.
So we found that actually it probably disintegrates a little bit earlier than what it's meant to. And it's proposed to have this anti-scarring agent. But in our cases, it didn't work as well as expected, and hence we stopped using it now. But I know a lot of people do have some success with it in certain scenarios, and by all means continue with it. How was your experience?
Yes, my experience is that in many cases, in case of mitomycin, there is a hypotonia or like this, and thin bleb is there. But in case of Ologen, I get better result, diffuse bleb, and it is at least I did 40 to 50 patient, and maximum I get better result, at least in the postoperative bleb and other things. So I was not dissatisfied. Average is okay. I think.
Good.
I didn't
sir, suppose you have a patient, you have done standard trabeculectomy, and the next day you find the AC is shallow. What would you do?
Shallow, first whatever we do, first try to give some. First I try to see whether any leaking point is there.
Yes.
We give some dye and see whether any leaking point is there. If there is leaking point, if there is a small, you can give the patch and rest. Sometime it forms, dilate the pupil, all this thing. And if it is not there, then we see for other things.
Choroidal folds বা
choroidal detachment is there.
আপনি কি রিসুচারিং কথা ভাববেন আর কখন ভাববেন?
এটা ভাববো আরো পরে। আমরা প্রথমে দেখব যে তার choroidal detachment আছে কিনা। তার অন্য কোনো ছোট লিকিং স্মল লিক হলে পরে ওই প্যাচ দেওয়ার পরে ডাইলেট করলে
কিন্তু ওটা পারসিস্ট করছে লিকটা, তখন
পারসিস্ট করলে তখন তো করতে হবে আর কি, তখন তো এটাকে ওই ব্লেডটাকে নতুন করে একটু
বেশ মানে তখন একটা সুচারিং এর। স্যার আপনাকে আমার আরেকটা প্রশ্ন, ধরুন পেশেন্টের গ্লোকোমা তো আমরা ডায়াগনোসিস করে নিয়েছি, ওষুধ সে দিচ্ছে, এবার ওষুধ দিয়ে সে আনহ্যাপি খুব, মানে তার চোখ লাল হচ্ছে, সে ওষুধ দিতে পারছে না, নন কমপ্লায়েন্ট, তখন আপনি কিভাবে এগোবেন? ধরুন প্রস্টাগ্ল্যান্ডিন দিয়ে চোখ লাল হচ্ছে বা অন্য কোনো ওষুধ দিচ্ছে, আপনি প্রিজারভেটিভ ফ্রি ইউজ করেছেন, তাও the patient is not happy with the drops, আপনি তখন কি করবেন?
মানে বিফোর সার্জারি বলতেছেন আপনি?
না নরমালি একটা পেশেন্ট এসে আপনি ডায়াগনোসিস করেছেন তার গ্লোকোমা,
ইনটলারেন্ট টু দ্য ড্রাগস,
কি করবেন তখন?
এখন তো আমরা ড্রাগ চেঞ্জ করে দিয়ে ট্রাই করি, বিভিন্ন রকম, একটা না হলে একটা ড্রপ দিই বা করি। একবারে যদি ইনটলারেন্ট হয় তখন তাকে সার্জারি করতেই হবে, হয় লেজার অথবা সার্জারির দিকে যেতে হবে, তাকে বলতে হবে সার্জারির প্রস অ্যান্ড কনস এই হতে পারে, ওই হতে পারে, তারপর ওই সার্জারির দিকে যেতে হয় তখন আর কি। এটাই তো নরমাল,
মানে এটাই নরমাল স্ট্র্যাটেজি।
You can ask him also.
So the question was that what would you do for a patient who's very unfriendly with the drops? He or she doesn't want to use the drops. So would you advocate surgery or some other line of treatment is available?
So I think it depends on the pressure, it depends on how advanced the glaucoma is, if the patient is phakic or not, and I think you have to take the patient's own considerations about their fears about surgery or cost of surgery versus laser as well.
Okay.
I would generally try and do laser in these situations.
Okay.
And plenty of them are very happy after one round of laser. But if the pressure is very, very high, you know that laser can only do so much, about the equivalent of one drop. So if it's too high and I think beyond the range of laser, then you'd start to talk to them about things like minimally invasive glaucoma surgeries. Perhaps.
Right. So minimally invasive glaucoma surgery আমরা এখন শুরু করব। তো আপনার আরিফ স্যার, আপনাকে আমি আর একটা জাস্ট প্রশ্ন, মানে আপনি মিনিমালি ইনভেসিভ গ্লোকোমা সার্জারি সম্বন্ধে পেশেন্টকে কি করে কাউন্সেলিং করবেন এবং কিভাবে আমরা এগোবো, মানে মাই কোয়েশ্চেন টু হিম ইজ অ্যাবাউট MIGS. How would I go about counseling a patient of glaucoma to do MIGS and not a trap? Do you get my point?
Yeah.
So I'm pushing MIGS and not a standard trap or trap with margin. So কোনটা ভালো, কোনটা কিরকম ভাবে এগোবো, তো সেই ব্যাপারে যদি একটু জানান।
ব্যক্তিগতভাবে আমি MIGS করি নাই, একটু
ওকে,
করা হয় না। আমাদের দেশে করা হয় অল্প স্বল্প, কিন্তু প্রথম জিনিস হচ্ছে যে এখানে ওই ডিভাইসটা পাওয়া যায় না, খুব একটা পাওয়া গেলে কস্টলি, এবং দ্বিতীয়ত এখানে খুব ট্রেন পার্সন খুব একটা নেই, কোনো কোনো দু একটা সেন্টারে হয় আর কি।
আচ্ছা,
তবে এরকম কেজে আমরা মোস্টলি আমি সাজেস্ট করি, বিশেষ করে যাদের ক্যাটারাক্ট অপারেশন, ক্যাটারাক্ট সাথে ক্যাটারাক্ট উইথ গ্লুকোমা, ইন দোজ কেজেস আফটার ফ্যাকো সার্জারি অর সামথিং ইউ ক্যান ইউজ ইট ভেরি ইজিলি, অ্যান্ড দেয়ার আর সাম মোর অ্যাপস ডিভাইস আর দেয়ার, বাট এখন পেশেন্টকে বোঝাতে হবে এটার রেজাল্ট ইজ নট টিল নাও, সো ফার আই নো, it is not as good as
মানে আপনি বলছেন গোল্ড স্ট্যান্ডার্ড ইজ স্টিল ট্র্যাপ,
still gold standard is trap.
Yes,
MIGS is not as good as trap, so far I know.
Okay.
And I talked with the other glaucoma surgeons, they are those who are doing routine glaucoma.
Okay.
So I can tell the patient যে it is non-invasive, এটা আমি বুঝাইতে পারি non-invasive, এটা কমপ্লিকেশন কম, এটা যদি আপনার সামর্থ্য থাকে এবং যদি ভালো সার্জন হয়, ইট ইজ বেটার। ইউ ক্যান ডু, মানে গ্লুকোমা এই ট্রাপিকোলেক্টমি তো একটা ইন্টারভেনশন সার্জারি এবং এর কমপ্লিকেশন অনেক বেশি।
ওকে, সো
হ্যাঁ, ইন কেস অফ এই সার্জারিটাতে পেশেন্ট অনেক কমফোর্টেবল, পেশেন্ট যদি
will interrupt now just a minute, a small break, but after the break the role of MIGS, the question is yours.
Yes,
okay, thank you.
Dr. Pereira, the $1,000,000 question, role of MIGS, where does it stand in the gamut of treatment of glaucoma?
The whole term minimally invasive glaucoma surgery encompasses a whole series of devices and types of techniques of surgery. Those that are based in the angle, those that drain into the subconjunctival space, and those that drain into the suprachoroidal space.
Right.
And they're quite wildly different from each other.
Right.
Yet they're still grouped under minimally invasive glaucoma surgery.
Okay.
Now, trabeculectomy is our mainstay. It's been around for 70 years. And it's used in most scenarios. And remember, there are markets where there are no minimally invasive glaucoma surgery devices available. In a lot of parts of the world.
A lot of parts. Here itself,
There are some places where it's expensive.
Yes,
they can't afford it.
Yeah.
But for a certain group of patients, it is very useful. It carries what we generally say is very, very low risks. But the efficacy is not as good as a trabeculectomy. And it's more expensive. But the key thing that patients like to see is that the risks are very, very low. So for a certain group, it's very appropriate. And we like to see the group that has got basically open angle glaucoma on 2 drops with cataract. They will do very, very well with a phaco and a angle MIGS.
So what would you use, Hydrus or iStent?
Right. So we're fortunate in Singapore that we have a whole series of angle devices available to us. But it's unethical that everyone gets to train on every single device. So we had to narrow down our strategy. So we've chosen for that angle Hydrus and the iStent Infinite. Which is the latest version of the iStent. People will pick the surgery depending on what type they're more confident with, the evidence base for it, the price. And
can I just ask you, what would be the price of hydrous implant in surgery? Yeah.
So currently at the moment we have extremely good pricing for the hydrous and the iStent. In fact, in Singapore, which is probably one of the most countries with the highest cost of living, we have the cheapest price of the hydrous and iStent worldwide.
So
we're very lucky.
Okay, great.
So it's actually about 1,200 Singapore dollars.
Okay. I had a notion. This is just a blank thing. আমি মনে করি যে too much of prostaglandin use destroys the conjunctival fibroblast or it alters it. Am I right or am I wrong? I do not know. I want to know from the expert that if I use prostaglandins for a very, very long time, is the rate of success in trabeculectomy lower than if I had operated earlier?
Yes, it is also my question. You answer it.
So there's a very good study by David Broadway which looks at exactly that question, and actually he phrased it slightly differently. He looks at the number of drops used. Okay, so the more drops that you use, more
of PGAs or any drop.
So he looks at the survival curves for trabeculectomy.
Okay.
With 1 drop, 2 drops, 3 drops, 4 drops. It drops quite dramatically.
Okay.
So the more drops you use, the survival of trabeculectomy is significantly effective. That's why some people give drop holidays. For example, they will give get the patient off all the drops and give Diamox for some period of time. So that they don't have to have any drops or any preservatives affecting the conjunctiva, and that's been shown to be useful. Also, giving drugs like steroids, topical steroids for a short time before the trabeculectomy has also been shown to increase the success rate. But of course, you can't give it for too long because
it will increase the pressure.
Absolutely right.
Okay, so that's a good thing. Drop holiday. এটা আমরা খুব ভালো শিখলাম. এটা দারুণ শেখা হলো. মানে প্রশ্নটা আবার দুজনকেই আমি করছি। Patients come. You can't choose what patient. You will get the patients. So a young child has come and intraocular pressures are high. What would be your mode of treatment? Young child, 8 or 9 years old. So not obviously ophthalmic, but elevated pressures. You could just have a sneak into the peep into the eye and you see the cup disc ratio is high. That reminds me, sir, before I ask this, can I ask you one question?
Sure.
You have a study as a lead author saying the Heidelberg cup disc ratio is not a good parameter of glaucoma damage, nerve damage, if I'm not wrong.
I think if I can just summarize the study, we looked at the agreement between the HRT and the OCT looking at cup disc ratio versus human measurements.
Okay.
And it was not quite so...
so which one was better? Human measurement was better?
No, human measurement we would regard as the gold standard. So the OCT and the HRT were compared against the human measurement. And human measurement doesn't mean roughly 0.5, 0.7. We measured it. We measured the...
How do you measure it?
With a graticule.
With a graticule.
So we've measured, let's just give you an example.
Okay.
Like let's say 20.
Yeah.
And the cup disc was, let's say, 15.
Okay.
So it would be 0.75.
Okay. So that is how you did, and the HR
gives
Heidelberg gives a cup disc ratio which is not in agreement with this.
Well, we would generally say that the OCT would tend to give you a larger cup disc ratio and the HRT will give you a smaller one.
Okay.
Because the way that's differently measured.
In a OCT RNFL, what do you actually see? Do you see the cup disc or do you see the retinal fiber thickness only? I mean, how important is the measurement of the cup disc ratio in a OCT compared to RNFL thickness? Obviously, RNFL thickness is much more important.
Of course. We only did that study because we had both machines giving you that one parameter. So we wanted to compare against an external observer how these machines did. That's the only reason why we did that study.
Okay.
But in real life, there are lots of other parameters as well that we would look at.
Sure.
Yeah.
So coming back to that question of a young child, I face young childs, I look after ROPs, I look after many other, so this patient and has elevated glaucoma, mother and father are worried, how would you go about the treatment? Sir, আপনি কি করবেন আর উনি কি করবেন? 8 থেকে 9 বছর।
8 থেকে 9 বছর। এখানে তার কোনো বোপথালমাস নেই।
No. Elevated pressures and increased CDR.
It is CDR. Increased CDR.
Yeah. CDR is increased.
We also check the corneal thickness. What is corneal thickness? দেখব এবং এই in this type of cases actually difficult to treat. We will see the progress of the disease. First we start, my opinion, I will start with drop medication. আচ্ছা আমরা ওষুধ দিয়ে ড্রপ দিয়ে আমরা দেখব বাচ্চাকে একটু কমানো যায় কিনা। কিন্তু যে একটা জিনিস বললেন লম্বা সময় ড্রপ দিলে অনেক কমপ্লিকেশন হতে পারে, তারপরেও প্রথমে দেখতে হবে যে ড্রপ দিয়ে মানে মিনিমাম ড্রপ দিয়ে কন্ট্রোল হয় কিনা। কিন্তু যদি না হয় তখন তো বাধ্য হয়ে যেতে হবে, কারণ বাচ্চাদের ট্রাবেকুলেক্টমি বা অপারেশন করেন সেটা মানে সাকসেস রেট খুব বেশি ভালো না। তারপরেও যদি একবারে চোখ বাঁচাতে হয় তখন যেতে হবে। তবু তার আগে ভালো করে ওই জিনিসগুলো ইনভেস্টিগেশন করতে হবে। একটা হলো যে কর্নিয়াল থিকনেস, দ্বিতীয়টা অ্যাঙ্গেল দেখতে হবে, অ্যাঙ্গেলে তার কনজেনিটালি অ্যাঙ্গেলে কোনো ডিফর্মিটি আছে কিনা, এবং অন্যান্য জিনিস দেখে তখন
ছোট বাচ্চা তো আপনাকে দেখতে দেবে না, জিএ করে ইউএ করে দেখতে হবে। Sir, how would you approach such a child?
So I think I understood what you were saying was initially start drops and then if not amenable to if that doesn't control the situation then move over to a surgery. So I think I would totally agree with that.
Okay.
The types of surgery that you can do for this 8-year-old really depends on how advanced the glaucoma is, the appearance of the angle.
Okay.
In this case, in case of these children, we cannot do the gonioscopy and other things. What is the role of anterior segment OCT in this case to assess the angle of anterior chamber? Do it or something?
I mean, we will do an examination under anesthesia.
Yes.
To
look at the angles.
Yes, then you can do gonioscopy also.
You have to do the EUA, take a handhold Perkins, measure the IOP, take the corneal diameter, that is obvious, and if you find something in the angle, incise, right?
And as axial length as well.
And the axial length as well, right? So would you incise? You would do your trabeculotomy?
So a goniotomy.
Yeah, goniotomy
works extremely well in these cases. It's the first line treatment. You don't disturb the conjunctiva. It's been proven to be.
8 years is too old, I think, for goniotomy and others.
I think it depends. Yeah. So often we may go to a so trabeculotomy and trabeculectomy together. Yeah.
Oh, so you would do a trabeculotomy and a trabeculectomy
combined.
Yeah. Okay, thank you very much, sir. A small break, and after the break, some interesting questions again. Sir, I had a question that what would be the minimum size of a trabeculectomy opening for the bleb to function? Is there any size, or does the size of the trabeculotomy opening, if I make a larger opening, that will create a larger bleb? Very shortly, yes, no, maybe.
There is no great study on this, but we would generally say something that it's about a third of the width of the trabeculectomy flap.
Third of the width of the trabeculum. Do you use a trabeculotome?
No,
or do you
a Kelly's punch?
Oh, you use a Kelly's punch.
Okay. So a Kelly's punch, I think it takes out 0.75 millimeters squared of the sclerotrabecular window. So about 3 punches should be just nice. And remember, that's not the limiting factor for IOP lowering. The limiting factor is still the absorption of the conjunctiva and scarring there.
Yes, scarring and the And do you suture it with one suture or 3 sutures on either side? Triangular flap, rectangular flap? What?
So we do a trapezoidal flap like this.
Okay. And suture it at either end?
So we do one releasable and one fixed.
Oh, so one releasable, one fixed, and the releasable is post-op.
Absolutely.
Done.
Yeah.
Okay, so we are coming to a close. We had a wonderful discussion, believe me, Dr. Pereira and Dr. Rahman sir. I have learned a lot. Though I am not a glaucoma specialist, I am going to now follow one thing, that's the injection. Okay. So your area is, I know, imaging and surgical devices and latest in medical technology. So tell us something about sustained release formulations that are upcoming, very short on gene modifications, gene therapy in glaucoma, and if possible the role of AI in ophthalmology, and then we will just wrap it up. Okay. Small, 2 minutes, 2 minutes, 2 minutes each.
Just for our knowledge.
So slow release medications for glaucoma have been one of the big goals for glaucoma specialists, and we would love to give something that would get maybe 6 months or 1 year treatment just by one dose, for example.
Yes.
But in reality, there are a lot of complications about how this is actually instituted. Cost is one thing. Does it need to be done as a surgery? Can it be done on a slit lamp? And there are several different routes of administration. So essentially there are 3 main routes. So one is as a punctal plug, 2 or external, 2 is a some conjunctival injection, or 3 is intraocular, inside the eye.
Okay. So,
Now, presently, there's really only one available treatment worldwide, which is called Durista, which is marketed by Allergan, and it's their intracameral implant that you inject inside the eye, the anterior chamber, and it stays there. Yeah, correct. Yeah.
What is it, over the iris?
No, it's inside the limbus. It's inside.
Limbus.
Yeah, it's something like we use in retina. So slowly it dissolves. So instead of multiple Lucentis injections, we have these implants now. So similar implant
similar
is
to the Osidex that you use for the retina. Now the problem with this, though, it's only been licensed for a single injection because the actual vehicle doesn't dissolve at the same rate as the drugs eluted.
Oh, so the vehicle remains.
Yes.
And that's a problem, right?
That's a problem because if you put a second one in, then it can move around and cause...
Right, and then the patient will have floaters.
Not just that, but they call it a compensation.
Oh my God.
Yeah. so that's why it's only been allowed as a single, allowed in the US as a single one.
You have done several studies on genes, very shortly.
Yeah.
What's the horizon? In 3-4 years, we have some optic nerve regeneration? Just...
Regeneration, probably no.
No.
I think that's going to be very difficult because, as you know, like the brain, the optic nerve does not regenerate, and I think that's going to be a fundamentally difficult problem to solve. However, there will be some work probably in gene therapy for lowering the IOP.
Okay.
Yeah, so I think that might be a more suitable target. Also.
Right. Right. That's good. Arif sir, we are the end. একটা শেষ প্রশ্ন আপনাকে দিয়ে আমি শেষ করতে চাইছি। সো আপনি আছেন, আমাদের তো গ্লোকোমা নিয়ে বিস্তর আলোচনা হলো, সব কিছুই হলো। একটা পেশেন্টের যখন গ্লোকোমা আর ক্যাটারাক্ট থাকে, আপনি কি একসাথে দুটো করেন, না আগে আপনি ক্যাটারাক্ট বা ফেকো করে তারপর গ্লোকোমা করেন, আর কোনটা করলে ভালো হয় সেটা আপনার কাছ থেকে আমি একটু জানতে চাইব। মানে পেশেন্ট হ্যাজ বোথ ক্যাটারাক্ট অ্যান্ড গ্লোকোমা, so would you do a phaco trab or would you do a phaco first and a trab later?
কিছু কিছু আছে গ্লোকোমা আছে, যেমন ধরেন অ্যাঙ্গেল ক্লোজার গ্লোকোমা ডিউ টু মানে লেন্স ইনডিউসড গ্লোকোমা, এগুলো লেন্সের ক্যাটারাক্ট হওয়ার জন্যই গ্লোকোমাটা হয়ে গেছে। এই সময় থেকে যে আমরা দেখি অ্যাঙ্গেলটা কত দিনের ব্লক দেখে নিই গুণস্কোপি করে, তো এই সমস্ত থেকে যে আমার বেটার হয় যে ওই শুধুমাত্র ক্যাটারাক্ট করে দিলে দেখা যায় ঠিক হয়ে যায়। আবার কিছু কিছু কেসে যদি লং টার্ম হয়ে যায়, অনেক দিন হয়ে গেছে, ইভেন ফ্যাকোলাইটিক গ্লোকোমা, ইফ ইট ইজ লং টাইম দেন অ্যাঙ্গেল ফিক্সড হয়ে গিয়েছে, তখন ওই সমস্ত কেসে আমরা পেশেন্টকে বলে বুঝিয়ে পেশেন্ট অ্যাগ্রি করে তারপরে আমরা এখানে কম্বাইন অপারেশন করি। কম্বাইন ইজ বেটার ইন দিস কেস। আবার অনেক পেশেন্ট তারাই নিজেরাই বলে যে আমাকে ক্যাটেট করে দেন, পরে আমিও ড্রপ ইউজ করে আমাকে গ্লুকোমা করে দিন না। এটা কোনো কোনো পেশেন্ট কিন্তু এইভাবে অ্যাপ্রোচ করে। তো বেটার ইফ ইট ইজ লং টার্ম গ্লুকোমা উইথ ক্যাটারাক্ট, ইট ইজ বেটার টু ডু কম্বাইন্ড সার্জারি। আর ইন কেস অফ লেন্স ইনডিউসড গ্লুকোমা কুইকলি short duration, in that case if we do the cataract surgery, I think it will be okay for the
ওকে
আচ্ছা
ঠিক আছে আমরা একদম শেষে চলে এসেছি শেষ পর্যায়ে চলে এসেছি ইট হ্যাজ বিন অ্যান অনার to share this platform with you, Dr. Pereira, for your enlightening remarks so much. I feel that I have maybe learned 0.0005% of what you know.
একটা জিনিস একটু জানতে চাইলাম যাওয়া হয় নাই যে একটু মিস করেছি actually nowadays worldwide talking about role of AI in different diseases and everything. I think AI also nowadays uses in case of diagnosis or treatment of glaucoma. Can we give some light regarding use of AI in glaucoma?
Sure. Exactly as you said, it shows a lot of promise in diagnosing, glaucoma maybe earlier than humans would be able to do. And I think that we are looking still at what platform to use the AI on. Is it going to be done on a
diagnosis
photo?
Yeah.
Okay, or is it going to be done on an OCT?
OCT.
Because on a photo you can look at other things as well in conjunction, diabetic retinopathy, any other problems as well with a wide field photograph. But on the OCT, I think there's a lot of promise there. Able to look at all the information that's gathered. Remember, when you do an OCT, it's not just a disc, it's a 3D volume scan that's taken.
Yes.
And we're learning so much more from the AI diagnostics about that whole area.
Right.
So I think it's a lot of promise. There's nothing available commercially at the moment, but I think watch this space.
Okay. So just
thank you very much. Thank you.
থ্যাংক ইউ আরিফ স্যার আপনাকেও থ্যাংক ইউ আমরা কিন্তু সুন্দর একটা সকাল কাটালাম একটা এতে আশা করি আরও আমাদের এরকম ডিসকাশন হবে অ্যান্ড উই উড লাইক টু থ্যাংক ডক্টর পেরেরা অ্যান্ড সো আজগর আলী হসপিটালকে আমি ধন্যবাদ জানাচ্ছি যে এত সুন্দর একটা আয়োজন আমাদের করে দিয়েছে ওনাকে ডাকা হয়েছে ওনার সাথে আমরা ইন্টারঅ্যাক্ট করতে পেরেছি থ্যাংক ইউ আজগর আলী হসপিটাল অ্যান্ড থ্যাংক ইউ স্যার অ্যাগেন